Sorry, because everybody did agree to that. My apologies for anybody who's joining that we haven't done that. Yep. So when does hydronephrosis of pregnancy begin?
Um, when the baby gets big enough. I don't know
Okay.
exactly when.
Anybody want to throw in a number? How many weeks?
20 weeks.
Okay. Anyone want to go lower?
9.
Yeah. Yep. Yeah, it can start as early as 9 weeks, which is why people say it's not just due to physical obstruction, because at that size, it shouldn't be causing that. So it's probably a combination of both hormonal changes and physical obstruction. The other important thing that you mentioned about this is that it is always worse on the right than the left. It also can persist for a few weeks after delivery. Exactly how many tends to vary, but certainly up to a month has been reported. It tends to be more as you go further into the pregnancy. So, it's pretty uncommon at 9 or 10 weeks. I'm not sure, don't think I've ever seen it quite that early. But once you get to 35 weeks, it's very common, and almost all women will have at least mild hydronephrosis of the right kidney. Can be equal, but usually a bit more prominent on the right than the left. And it can cause a really big query when you've got someone who's got a lot of pain and got hydronephrosis. Is it just that? Or is there, say, an underlying stone? You can't do a CT to find out. So you have to look carefully. And the other thing, as you've said, is they try all sorts of various maneuvers. You can get the lady to lie on her side. They also, if they think it's causing a lot of pain, they will tell ladies to kneel on all fours for a number of hours every day and see if that helps, which I think must be really uncomfortable. But, you know, I guess obstetricians are used to women being in uncomfortable situations. So, again, something that you kind of need to know about because you're likely to come across it. And of course, again, the biggest query is if you have someone like this who then does have some leukocytes and nitrites in their urine, is this now an obstructed infected kidney, or is it just hydronephrosis of pregnancy in someone who coincidentally has some cystitis or, a mild UTI, which obviously make quite a big difference in terms of management. So it is something that you need to try and work out. Okay. Let's see. Let's go back to one of these ones from here. Um, oh, here we go. This one's not really that.
Sorry, Adrian, was that just physiological in that case then,
Yeah.
or
Yes.
yes?
Yeah. Yeah. So her urine was, I'm pretty sure her urine was clear, which does make it a lot easier because, I guess if you do miss a stone, it's unpleasant, but if it's not infected, because, if you diagnose a stone, most of them are going to be small and you're going to go, all right, well, we're not going to do anything at the moment as long as you're not in renal failure. So they won't actually do anything interventional anyway. So it's mainly in the query if you're querying an infection there. And as I said, the vast majority of them are going to turn out to be hydronephrosis of pregnancy. But you've got to try and make sure. Okay.
Hey, Adrian,
Yeah.
I've if you go and look up I think it's the most recent Life in the Fast Lane ultrasound case, is one that I put up, which was a woman who was it 30 weeks and had hydronephrosis and actually ruptured her calyces and had like urinoma around her kidney.
Mm,
And that was one where she almost got to theatre to get stents put in, but her pain
mm.
settled down, presumably because she ruptured.
Probably because, yeah.
Um, we looked it up. There's only 40 reported cases in the history of the medical literature. So there you
Mm,
go. So they can actually rupture, but it's pretty rare.
okay.
But there's some pictures on Life in the Fast Lane if anyone
Oh,
gets
thank
bored.
you. Thank you for that. All right. This one, as I said, this is just a. So this is someone who they were trying to catheterize and having trouble. And for those of you who've never used ultrasound in this circumstance, I suspect most people have. It is quite useful, I find. First of all, for the cases where people keep insisting that they're definitely in the bladder, and yet nothing seems to be coming out, or they were, or something, and there's some blood and they're not sure. The easiest thing is to have a look. The bladder's empty, it gets a little more tricky, but sometimes it can be quite useful to actually watch things. And the main thing here is just to recognize the anatomy. This is a rather generously sized prostate here. This is the catheter attempting to be advanced through the prostate. That is not getting anywhere near the actual bladder. So in this case, we could just say to them, look, no, that's just not going anywhere. But this was someone who had a catheter in, had the balloon blown up, nothing, a little bit came out, everybody was like, no, it definitely came out. And sometimes I have seen this where the balloon is in here, but the tip just comes through into the bladder, and you can see why they got a little bit of drainage from there. But as for procedural guidance, it's actually quite nice. So I'll stop that a moment. Just in passing. This is an elderly gentleman who says he's got a lot of problems peeing in the past. And when you put the probe on, that's what you see. Okay, Andy? No, it's only a single image, but
Yeah, so there's two large cystic structures here
yes.
to me, pelvis, and I suppose the question is one of them the bladder and another of them a large pelvic cyst? That's currently my thought process at the moment.
Yep. So I guess the first thing is double check and make sure the gender of the patient would be helpful because...
Oh, yeah. Did you say this is an elderly man? Sorry, or did I?
Yep, this is a man.
Yes, okay, cool.
Biologically and whatever the term is these days. So, yep. Okay, good. Yep. So what do you think the cystic structure might be?
I'm not sure. Sorry. Yeah. I mean, other than just a pelvic cyst or something that is.
Yeah. What sort of pelvic cysts do men get?
I'm actually not sure. I mean, obviously in women we think about ovarian cysts would be the most common. In men, I'm actually not sure. Sorry.
Okay. All right. Anybody want to throw anything in?
Is it a bladder diverticulum?
Yep. Bladder diverticulum. Absolutely. And in old men, that's probably the most likely thing. Yep. What if you looked at it?
AAA?
Yep. Well, an aneurysm of something of that size. Yep. AAA. Yep. I mean, I know it's unfair because it's a still image, but yep. Okay. Lymphadenopathy, I mean, that would be massive. But enlarged
dilated bowel, but it doesn't really have the
Yep.
sonographic signature of a bowel.
Yeah, but then again, when bowel gets really dilated, it gets very thin-walled and it's really hard to see. So, yep, so all of those things. In younger people, and I've got to say most of the ones I've seen have been in females rather than males, lymphangioma as well, so lymphatic malformation. Often I've had a few cases of teenage either young girls, teenage girls, or young ladies who've got a bit large cystic structure in the pelvis, and they have generally been thought to be ovarian, but when they go to theatre, they turn out to be lymphangioma, so lymphatic malformation. Okay, so that's always worth throwing in the differential as well. Be unlikely to get to this guy's age without that having never been found. Okay, so what's going to be your way to find out?
So I would like to put color on and look for ureteric jets. So that
Yep.
might be something that helps.
Yeah, they're going to come out in the bladder. The
Yes.
ureteric jets, not so much in here.
Yeah, sorry. So just to
yeah.
confirm which one was the bladder, but I
Yep.
suppose anatomically that's going to be
Yeah,
the
yeah,
one.
yeah. I mean, I know I'm only showing you the longitudinal here, but yep. So this is the
Yeah.
bladder.
Yep.
And this is the cystic mass.
So then it would be useful to obviously fan through and see if it connects with any other adjacent structures.
Yep.
If there's any internal septations, any
Yep.
vascularity of the septations if they were there, or vascularity
Yep.
of the wall.
Yep.
It I may increase the gain as well and just see what the internal contents of that structure looks like.
Yep. Yep.
And yeah, that's how I'd approach trying to
Okay.
identify what
All right.
structure was.
If it's a bladder diverticulum, what do you think's going to happen if he empties his bladder?
So it should decompress if you empty the bladder or catheterize him.
Yeah. Yep. So have a look there as well.
Oh yeah.
And we'll put colour on. You can actually see a little bit there. And when you're a bit mean and pressed on the mass, which he didn't really like, I must admit, you could see the colour go this way. And then when you took the pressure off, the colour came back out that way, which sort of suggested that there's a communication between these two things, and therefore it's a bladder diverticulum. So yeah, unsurprisingly, he had bilateral hydronephrosis. So if you've got bilateral hydronephrosis, you should have a sort of list of the commonest causes in the different age groups and the different genders for that. So what would you think in this guy?
So in an elderly male, then prostatic hypertrophy
Yep.
would be most likely cause, so BBH or prostatic cancer.
Yeah, so bladder outlet obstruction. Yeah, I don't think cancer actually causes it that much. It's usually just hypertrophy that gives the obstruction. So yeah, because both ureters are dilated, you've either got to have two separate pathologies like bilateral stones, happens, but not that common, or you've got to have an obstruction that's after where the ureters come to a common point, which is the bladder. So sorts of things are BPH. What about in a lady? An elderly lady, bilateral hydronephrosis.
So I suppose again it would be bladder outflow obstruction. It would just be a different cause. So it might be. Can prolapse pathology cause bladder outflow obstruction? No.
Yeah, not commonly. I mean, most elderly ladies don't have problems with outflow obstruction.
Okay.
They tend to have problems with incontinence more than anything.
Yeah.
Yeah.
And we're talking bilateral hydronephrosis.
Yeah.
Yeah. I'm not sure. Sorry.
Okay. So I would think something like pelvic masses. So not the actual bladder, just proximal to the bladder, things like large ovarian masses, most commonly, but you can also get the same thing with retroperitoneal masses, with lymphoma is the commonest retroperitoneal thing. You can also have it with fibrosis. What's the term I'm thinking of? Retroperitoneal fibrosis, where you get a mass there that can compress the ureters as well. What about kids? What about a young boy?
So in a pediatric patient, I'd be thinking along the lines of something more congenital. And that may be like some of the pathology we talked about earlier, like duplex collecting systems.
Yeah, because you can get the reflux with it. Yep.
Flux.
Okay. What else do little boys get?
They can get also outflow obstruction, but urethral outflow obstruction.
Yep.
Really?
Yep. There's a word that
Not
if you're
paraphimosis.
if you're writing an exam, I guarantee there'll be a little mark for the word or the
Yeah,
phrase.
I lost it. Sorry, I can't remember.
Yeah. Posterior urethral valve.
Yeah.
Okay. In young boys, that's the absolute classic. How might you distinguish between reflux and posterior urethral valve? What do you think is going to happen to the bladder?
I'm not sure. Maybe someone else can help me out.
Same thing that happens to old guys' bladders with big prostates.
So they get post forward residual.
Yeah, yeah. What happens to a muscle when it's got to squeeze against an obstruction a lot?
Hypertrophied.
Yeah.
Bladder
Yeah.
wall.
Yeah. So you get hypertrophy, and whereas in reflux, you shouldn't get hypertrophy. So, I mean, the reality is that, in a young kid, that's not what they use to diagnose it. But you should know about posterior urethral valve in kids, and prostatism in the elderly, and then be able to rattle off a few causes for bilateral hydronephrosis for everyone in between. Okay. All right. Let's look at what else we got here. Oh yeah, I'll tell you this. This is a sort of classic sort of presentation. Okay. Who are we up to? I think Claire, are you able to talk? Are you?
I'll talk. I'll put
Yeah.
my dinner outside.
Right.
And I'm very early in my ultrasound journey, so
right.
the bar will be set very low.
That's okay. Okay. So this is someone who has presented with hematuria. Okay. So just having a look at that image, this transverse image of the bladder. Not a great picture, but it's mine, so I'm allowed to say how terrible it is. Yep. What do you notice?
So I noticed that there is a anechoic, presumably urine in the bladder, but there's also a hyperechoic mass sitting posteriorly. And the first thing that jumps to mind is that it's a blood clot, so hematoma in the bladder. There's a bit of other speckle in there, so there may be some other unclotted
so
in there.
I agree. First thought is that, I've said he's had hematuria. So first thought is it's blood clot. What's the second thought?
Mass, so like a bladder tumor that's on the posterior wall.
Yep. How are you going to tell the difference?
Roll the patient over. So do some positional maneuvers and see if it moves with the patient.
Yep.
I could put some colour flow in and see if there's any vascularity to it, if it was a tumour.
That's it, because those are the two things you've got to do. You've got to see, is it mobile and is there colour? Yep.
And it doesn't look like it's moved.
Nope.
He has, but the tumour from the position on the bladder.
And there wasn't actually any colour flow on there, but so that's going to be tumour. Yep. That was transitional cell carcinoma, which is another cause of bilateral hydronephrosis as well, by the way, because TCC can often spread across and obstruct both of the ureters. Okay.
And that's quite a common origin location for it in the bladder.
That I don't know. I don't know if it particularly affects the trigone of the bladder more so than other areas. If anybody does know, please help me out. But as I said, it's just one of the ways you can obstruct both of your ureters. Okay, great. And Okay. Here we go. I'm following up on that theme. Just to show you. So again, this is somebody else who had hematuria. And we can see there's two masses there. That mass has colour flow. There's a spectral Doppler trace of an arterial trace. And then looking at the longitudinal, the second mass, which is more echogenic, doesn't. And this is positioning them in the right lateral decubitus position. So that's one mass that's moved and one mass that hasn't moved. So we go back to there. So when we did it, this mass had colour flow and didn't move. This mass had no colour flow and did move. So this is tumour and this is not. Okay. And the next question would be, what else do we look for in a case like that?
Lymphadenopathy, hydronephrosis.
Yeah, hydronephrosis is important. Yeah. I mean, it's getting a little bit beyond what we do in emergency, but how do TCCs spread?
So local spread.
Yep. And
and up the ureter. So you're looking up for any infiltration of the pelvis, renal pelvis.
Yeah. So there was also the left kidney had this mass within an echogenic mass, sort of in the pelvic region of the kidney. So it was multifocal TCC, and I don't know which way it spread. I believe that's not that uncommon for TCC. But again, that's what the urologists are for, not us. Okay. The other one I wanted to show. Again, this is quite a common thing that you will be expected to know about. Salah, I think we're up with you.
Okay.
Yeah. Right. You want to describe that? Tell me what you think and what you're going to do.
Any more images or just this one?
That's all you need. It'll give the game away if I show you the rest, I think. I can't remember what the other ones are. Yep. It's a right kidney.
Right
I'll tell you
kidney.
that because it
Yeah.
doesn't have the description on it, but yep.
So the right kidney, I think it's in transverse.
No, longitudinal, I'm going to call that.
So that's the upper
Liver
pole
over
of the
the
right
top.
kidney?
Sorry?
Just the right pole, upper pole of the right kidney?
Yeah, so this is the kidney down here. Sorry, I know it's not labeled, it's only a single image.
Yeah.
So this is the liver. Yeah.
That's the liver. There is an echogenic mass within the upper pole of the right kidney.
Yeah.
There is it's rounded with no no shadowing behind, so no post acoustic shadowing. Probably my next step would be to try to look at this mass into planes and use color flow.
Yep.
Yeah, that's pretty much it.
All right. Yep. What do you think it is?
So it is.
There's your two planes.
Yeah.
Don't know if that helped you or not.
No, it didn't help
Rather
much, but it's
important.
small. It's around 1 centimeter.
Yeah.
So RCC will be highly high on my list
Yeah.
for this type of
Yeah. So
reason.
what do
Mm.
RCCs normally look like?
What I think they can be echogenic, or they could be also um, more.
What do they most commonly look like?
Not sure what's more commonly known. I'm not sure. The other thing that's common on looks like this in on a renal image could be the angiomyolymphoma AML.
Like lipoma.
Lipoma, so angiomyolipoma.
Yeah. All right.
Um,
And what do they look like?
They look like it's a combination of, depends on the content of the tumor, the lesion itself.
Yeah.
Um,
Typically.
they could be more echogenic with
Yeah. What's the lipoma bit mean?
fat. So it
Yeah.
depends. So they more look like
Is that the same
echogenic.
echogenicity as the fat surrounding the kidney?
Yes.
So yeah. So that's a very typical appearance of an angiomyolipoma. But, and this is where it gets a little bit tricky, a small percentage, and I think it's about 5%, but you should look it up, don't quote me, of renal cell carcinomas are also echogenic. Typically, renal cell carcinomas are more heterogeneous.
Yeah.
They may be cystic, but very occasionally, particularly the smaller ones, can just be echogenic, which is a bit of a problem because angiomyolipomas are a benign mass, and the general management of them is
Just monitoring and
not even monitoring. Once
Yeah.
you've said it's an angiomyolipoma and it's small, you just go, yeah, that's
but
it.
how you will be confident that this is definitely an angiomyolipoma?
That is a very good question. And so generally, so I guess the first thing is, what's the first thing you're going to say to the patient?
Did they have any previous imaging and then
Yep.
compare to old?
Compare it. Yep.
Yep.
And if it's been there before,
And it hasn't changed.
well, then yep. Then you go, that's fine. It's an angiomyolipoma. There are different recommendations. If you're in the US, of course, you get every sort of scan and every sort of test done to show, preferably an MRI, so they can make more money because it does pick up fat very nicely, and you can say it's definitely an angiomyolipoma. But a CT will also do that as well. If you're in somewhere like the NHS, I don't know currently, but certainly previously, they used to say if you're young and you have no risk factors, then you call it an angiomyolipoma and ignore it. The general recommendations are, because a small percent of RCCs can look like this, that you should get further imaging. Again, that's easy if you've got someone who's 60 years old. Sometimes it doesn't feel quite right when you've got a 20-year-old and you see this and you go, look, this is a 99.9% chance this is going to be an angiomyolipoma. But what is the threshold? So the straightforward answer, particularly in the exam, is you say this has all the typical characteristics of an angiomyolipoma, but because a small percentage of renal cell carcinomas can have the same appearance, I would recommend compare to old imaging, and if that is either not available or suspicious, then I would recommend further imaging, usually with a CT, to confirm that it's a fatty tissue, a fatty tumor, consistent with an angiomyolipoma. Some places will talk about using ultrasound contrast, but we don't tend to use that in Australia. So we tend to go for CT. And as I said, some people who may have a higher risk threshold may suggest in a young age group that you don't do anything. But the standard answer is you can't be absolutely sure, so you need to check with previous imaging or organise some further follow-up imaging to confirm that. make sure it's not a small RCC. No. I can't remember offhand how old this person was, but this was a typical angiomyolipoma. Final question on this is, what are the complications? I've just said most of the time you ignore them and do nothing.
Yeah.
Do you not ignore them once you're confident of the diagnosis? Right. This is a bit of a stretch question.
If they cause mass effect and if they cause obstruction.
Yeah, I mean, I guess that can happen. It's very, very rare. I think I might have seen it once. Can't remember exactly. Yeah.
Bleeding is the main risk from them. So once they're of a
Yep.
certain size, they
Yeah.
can be embolized or resected.
Yeah, so once they become large, so I mean, I guess you could say they all have a risk of bleeding, but the risk of bleeding is directly related to the size. So small ones virtually never give you any problem. Once they become large, then they can be a cause of bleeding, and they can bleed spontaneously. My recollection is usually, I think 4 centimeters is said to be the
Yes.
cutoff.
I had last week his case. Lady comes in, classic, in her 40s, left flank pain. She became unstable and she needed embolization.
Yep.
Yeah.
Yeah. So just to reinforce that, because let me find the damn thing.
Yeah, maybe a stupid question, but a junctional defect, the morphology of the echogenic structure in the upper pole is too wide. It's not it's too big to call that a junctional defect.
Yeah, so I mean, there's a couple of things you get. So one is you get enhanced fetal lobulation. So the kidney is formed by fusing 3 parts of the mesonephros or something. That's the point you go. So it's formed by 3 and they fuse, and usually that gives a smooth cortex, but sometimes you can get very prominent fetal lobulation that persists in some people. But of course, that doesn't look like that bright mass because it comes down into there. And the cortex goes around. So the pyramids, you can see the pyramids, and then you see the cortex around the edge of it. So it doesn't look like that. That's a very bright, discrete mass that's there. While we're talking, I'm just going to bring this up here. The other things you get, you can get a dromedary hump, in the left kidney where the spleen comes down. And so you've got to make sure you don't mistake that for a mass, because the outline of the kidney will look a little bit unusual. And usually it's straightforward, but sometimes it can be really quite tricky to distinguish. And if you're not sure, you can get somebody else to have a look. This is a guy who came in with pain. And we can see this looks like kidney in the inferior pole. And in the superior pole, there's a bright echogenic mass. All right. And then inferior to the kidney. So there we can see kidney, and then this bright mass. That looks like, the rain cloud sort of thing because of the fat. And when we came down inferiorly, there's some better pictures of it further on. Okay, one thing that's a much nicer picture, you can sort of see the kidney there, and then, right? And it's a sort of thing if you showed me that in isolation and said it was in the pelvis, I'd start thinking about a dermoid because of the fat content, except it's in the kidney. So it's going to be an AML. Oh, it doesn't show it quite so nicely, but around the edge of the kidney, there's this bit of fluid around here. So again, this is similar to the one you described, Dion. This was a retroperitoneal bleed from an angiomyolipoma that underwent embolization. He wasn't that unstable. He did drop his hemoglobin quite a bit. Had a lot of pain. Came in, initially everyone thought, oh, it's renal colic. You can sort of see around here, and then this is the fluid around. One thing you do need to be able to recognise is perinephric fluid as opposed to intra-abdominal free fluid. Okay. Because I haven't shown you any cases at the moment, but you do need to be able to distinguish those. Let's see if I just pull up one, just point that out. I've forgotten what else we were saying. Moment. You can all see that. So this is someone who presented again with right-sided pain. You can see the kidney with quite a lot of fluid around it. Actually, a lot. So on the left side, moment. So you see the kidney and then the fluid tracking around it. So you need to know the causes of that. You know, if that's blood, ruptured AML, or bleeding tumour, most commonly in AML. I have seen it in other tumours. I've also seen it from a previously undiagnosed AVM that bled that into the retroperitoneum. It can also be urine if you rupture a calyx, usually associated with a stone, which, as Casey mentioned before, his case with the pregnant lady, or the one on Life in the Fast Lane with the pregnant lady, you can see the kidney and all the fluid running around it. In this case, there was also a bit of a dilated ureter. Don't worry about the right side. Yeah, that's the final thing I want to mention. I need to talk about. And that was the cause in this case. So a stone with a ruptured calyx. But you will be expected to be able to look at an image and say that is intra-abdominal free fluid, or that is perinephric fluid in the retroperitoneum. Okay. Okay, pretty much running out of time. The final thing I wanted to mention is that you all need to know about renal cysts, and particularly about the Bosniak classification. Now, as I'm sure you're aware, the Bosniak classification is actually based on CT imaging, but it has been modified and adopted for use in ultrasound. And there are a couple of, there's actually not much. People just sort of use it, but there are a couple of papers where they have looked at it and shown that it is accurate to be used, particularly for minimally complicated cysts, which don't need further follow-up. But you need to be able to describe a cyst. You need to be able to describe what criteria you would say you would use to determine if you needed further follow-up, further imaging of cystic structures. So, you know, things like presence of septae, thickness of septae, number of septae, is there colour flow within the septae, is there nodularity in there, any other solid structures, is there calcification, because those are all things with the Bosniak classification. I'll leave you to look all those things up, rather than me just prattle them off, because you just, you know, you can look up a table of them. And as I said, so most of the stuff you'll find is based on CT, but you need to be able to say, all right, this is going to be the ultrasound equivalent, recognizing that when they're talking about contrast enhancement, that unless you're using ultrasound contrast, which we typically don't, then color Doppler does not have the same sensitivity as CT contrast when looking for vascularity and enhancement. Okay. All right. Has anybody got any other comments or questions? Anything that I've missed out that you think is a glaring hole? Okay. Casey, anything that I've missed, anything that I said that's wrong, I'll pretend not to hear if you tell them all that it was all garbage.
No, all good, man. The only thing I've learned recently about AMLs is I think there's a certain percentage that have an internal aneurysm within the AML. So if you can see that with color flow on the ultrasound, I think that's the group that seem to be at higher risk of bleeding, but
Yeah.
you're
Okay.
putting color flow on it anyway. So if you think it's an AML and you can see a central vessel, then it's probably not one I'd just say, oh, you're right, carry on with the rest of your life. I'd probably refer that one.
Yeah, well,
That's maybe
I
one.
didn't know that.
But I think if you're seeing color flow on something you think's an AML, you're probably going to get a CT or something anyway, because that's not typical of AMLs in general. But I think you only see that once they get big. So
Yeah,
Yep.
I would expect so. Yeah.
Yep.
And
I'm sure that Adam or one of our peds colleagues is going to talk about weird and funky pediatric renal stuff later, so we'll leave that for them.
Yep.
The other thing I learned about AMLs the other day, I had an incidental case and the patient had multiple ones diagnosed on CT. She was quite a young woman,
Yes.
but there's an
Yeah.
association with tuberous sclerosis. And
Yeah.
so the radiology reg was like, this is a classic exam question. So he gave me the whole, she needs to have a follow-up MRI of the brain spiel.
Yes.
And
Yep.
they were small enough that there wasn't the risk of bleeding. But that was the other interesting thing. So
Yes.
then I referred her on for further follow-up with the GP.
Did you check for cafe au lait spots or willow? Was it wintergreen? You got to put that on your report. It's so much cooler when you do that as a
with
TD.
ultrasound.
Yeah. It covered the cafe au lait spot with my job.
I thought the AML, if there's posterior acoustic enhancement, there's not a lot of them, but if they do have that, then can you be pretty reassured it's an AML and not a tumor?
It's one of these things where it's really hard to know where you need to draw the line to look for to make sure that they're not an uncommon presentation of something else. You know, and this becomes much more of an issue given the amount of imaging that people are having. And, you know, it sort of gets into that area of incidentalomas. Just how far do you go with these things? Because for that unusual case that turns out to be cancer, everyone's going to go, yeah, but you remember that, oh, we saved this person. Goodness, what would have happened if we missed this? You know, isn't it so lucky that they got this extra imaging and it just happened to pick this up? Of course, you have the flip side of what happened to the person who had further imaging and then either had an allergic reaction to the contrast, you know, and people have died from that. You know, there was the woman in Melbourne who their company generously gave all their senior staff CT coronary angios as part of their health and welfare package. And she had a severe allergic reaction and died. She had normal coronaries, but she died in the radiology, in the CT scanner from severe anaphylaxis. You know, and there's been cases of people having renal biopsies for what turned out to be normal or benign conditions, which then bled and then wound up with them having nephrectomies. You know, so it's really difficult. You know, I mean, this is something we deal with across all the investigations we do. But what should actually be the threshold to say we should do stuff? Gallbladder polyps, you need to know about gallbladder polyps. You look at the recommendations from even three years ago. I think they only changed about 2 years ago. all these people were suddenly, gallbladder polyps are common. And all these people were being recommended for lots of follow-up and or cholecystectomies just in case. And again, that's for the ones that turned out to have cancer, that was great, but they were few and far between. And if you do enough standard operations, you're going to get your standard complication rates and you're going to wind up doing more harm. So gallbladder polyps, the recommendations have now wound back a great deal on who needs further follow-up, who needs further investigation. Microlithiasis in the testes, same thing. That didn't tend to cause too much harm other than inconvenience, economic, and maybe a bit of psychological stress. But, the recommendations used to be, 6 monthly ultrasounds, and then maybe you could stretch it to a year. And now they go, no, as long as there's no other risk factors and no family history and so on, just testicular self-examination on a regular basis and don't do anything else. I think angiomyolipomas are in the same boat. Everybody knew that. I think I've got the figure of about 1% of the population based on autopsy studies have angiomyolipomas. So they're really common. We don't see them as often as they're there because if they're small, they're quite hard to distinguish from, the other pelvic fat and that sort of stuff. But as I said, what do you do when you get a 20-year-old with one of these things? And you just think, of course, this is going to be an AML. What is the threshold to say that is a reasonable situation to say you don't need anything more? You are right. The amount of shadowing tells you that it is more fat and therefore makes it less likely to be an RCC. So a lot of recommendations will say if you see that, you do not have to do any further investigation. But this is all part of people looking to try and dial back over investigation that we are causing by doing increased imaging. So it crosses a bit into a sort of broader discussion as well. But yes, you should look up what the current recommendations are for AML to make sure that particularly in the exam, as long as you come out with a reasonable set of relatively current rules, then everyone will say, yep, that's absolutely fine. If you start saying that every simple renal cyst needs contrast CT follow-up, then you're going to get marked down. But by the same token, if we show you something like an atypical AML, which is more heterogeneous, then you will be expected to say, no, that needs further follow-up and that needs further imaging to look at it. Okay, same with the liver lesions, those sorts of things. Okay, all right. I shall leave it there unless anybody else has got any other questions or comments.
Thank you so much, Adrian.
Okay, all right. Thank you, everybody. Okay, and I'll stop the recording and Casey, I'll put it in the Dropbox for you. Okay.
Oh, yeah. Thank you.
Yeah, sorry.
I can't remember what's on next week, team. It's something awesome. Hang on, let me check.